wasting more time, let me introduce our first speaker, Dr. Ashish Bacchav. These are his credentials. So more than 15 years of experience. So combined, the people on the dais have a combined experience of more than about 80 to 100 years of ophthalmological experience. So Dr. Ashish will talk to us about how to manage refractive cases and to avoid medical legal issues over there.
Thank you, Dr. Anand. Good morning, everyone. I'm Dr. Ashish. I'm going to speak about in detail about medical legal aspects in refractive surgery and things that we should do, small things that will help us in a long way to avoid litigations. And if we are in a litigation, how do we manage those? So I have no financial interest from this presentation. There were days when doctors were considered as next to God, lifesavers, sight savers. We know these things have changed considerably. We despite have specialization in the subject, still there are many allegations that come across very recently, more so in refractive, and cataract being also considered as a refractive surgery these days. We have to be careful. One should also keep in mind that we should accept cases only in topics that we have mastered on, and we should not take it as a business. This is data worldwide. We know more than 40 million, 91, little old data, 40 million people have undergone Lasik surgery. It is right now the most commonly performed refractive surgery, whether we are talking about surface ablations or Lasik. We all know that outcomes of these cases sometimes can be suboptimal. Unhappy patients will drag some of us to court. I will speak about few cases that happened recently, which led for us to open our eyes and think about what we can do, because any one of us can be in such a might land up in such a situation going forward. So there was a gentleman who underwent Lasik long back, and because of the residual astigmatism, he was advised toric IOL implantation. He was pretty unhappy with that, and he claimed 60 million plus as compensation. So this was a very famous case that went on in Delhi court. Of course, the courts are smart. They did not really give that compensation, and they said that because the complainant completed his studies and has a good quality of life right now, the compensation did not go through. But we have to be careful about that. Informed consent. Now we know about this. We all take consents in local language, native language, document it. But there have been instances where sometimes these papers have been missed or not brought through when it came up in the court of law. So if it is not documented, if the consent is not documented, it tells that it did not happen. So court has to see the informed consent. And in this particular case, it was not taken, even though it was done by good interest by the doctors themselves. This particular document was missing, and the doctor had to pay the compensation in this case. Professional indemnity, I think many of us, I'm sure many of us in this room, how much to the amount do we have as professional indemnity annually? Maybe 50 lakhs, 75 lakhs, but as a phaco-refractive or purely refractive surgeon, I think it should be in excess of 1 crore these days, especially in cities where anybody can sue us. It's the American way of life. And we have caught up with that. So in today's areas, compensations are more than 10 millions is very frequently awarded. So this happened with a person suing a doctor from South India, and the compensation that was asked for more than 10 million. Of course, that also did not go through in this particular case, but a lesser amount of compensation was awarded to the complainant by the court. This gives the importance of how important it is to have a good professional indemnity. So why do we have so many cases against doctors? Well, why are we seeing this trend of people suing you left, right, and center? Of course, it's in part for us to blame. Also, we have raised the expectation that it is good in my hands and it's a 5-minute procedure. Sutures, I don't take them. I have the best laser. I don't know about the other doctor. I'm much better than Dr. XYZ. Excessive advertising, and that raises the expectation from the patient, but sometimes in some cases the outcomes probably would not match what the expectations are. So that's what leads to a happy patient. We fail to understand what are the risk factors. Of course, something that was there in the history that we missed. Did we explain what are the complications, even if it is small, like STRI? There is a case on STRI also that was reported. And do we own up our complications, or do we just pass it on saying that, oh, it happens in surgery? Of course, that also talks about how transparent we are with our patients and our colleagues. So coming back to the consent, carrying out a surgery without an informed consent is a criminal liability or a civil liability in whichever court it is produced. This is not me, this is Chief Justice of India who's saying this. So always obtain informed written consent, whether it's English or regional local language, and document it about the procedure, the complications, what is the reasonable outcome, or if things go wrong, what can happen. If accepted procedure of intervention is required during surgery, that also has to be explained. Document it, and if the patient is refusing consent, even document that and keep it as an evidence with you. Of course, communication goes a long way in this. We should always explain the procedure in layman's language, whether it's Hindi, Marathi, or regional languages. It's always important to have those consent forms. We should avoid this coffee table talks and criticize, oh, that was done, oh, I wouldn't have done that in my case. We need to avoid those. We should have a user-friendly telephonic system. Even after surgery, the patient should have an emergency contact number. It need not be you, it can be somebody who will explain the procedure, calm down the nerves, and give the right advice to the patient to come back and have his consultation done. So we have to remove these barriers. We have to return calls after surgery and not forget about it as soon as the surgery is done, saying, wow, this was a good outcome. But for the patient, it's a life-changing surgery. They have to be informed about these things. Always in the medical report, we have to document it correctly. It is the documentation of importance if it comes in court of law. So we have to mention what was the diagnosis, when did the first come for this consultation, what were the investigations that we done, what is the present situation dated, and when is the next follow-up. All these things, thorough documentation is the key in these reports. Of course, it goes without saying, and I'm sure all of us follow a detailed history for these patients. Now coming to refractive surgery, we have to do a good workup. We have to rule out dry eyes. We know that it is going to cause some dry eye in some patient. This has to be communicated to the patient. So wherever it falls short, I think communication is the key for happy patients and good outcomes. Complications of Lasik, especially if you see something pre-op, has to be conveyed again, whether it's some corneal scars, some dystrophy, some erosions that happened previously, or in case when you need to change the procedure from Lasik to surface ablation PRK, we have to spend a lot of chair time, a lot of table time before we take the patient for surgery. This also includes professional aspects of the patient. For many of them come because they want to join the military or the merchant navy. Expectations are huge, so even a residual of 0.5, 0.75 makes a lot of difference to them. This has to be communicated well. For instance, in the US, if pilots with a Class A license undergoing LASIK, they are restricted from flying for 3 months. Of course, such rules are not there in India, but it depends from region to region, state to state, and these have to be kept in mind before promising that, oh, you will be good to apply for these surgeries. Of course, when it comes to presbyopic correction with laser, you have to counsel that this is what we have, depending on the age of the patient, depending on the comorbidities that they have, and the chances of having a requirement for a cataract surgery later on in life. So examine carefully, especially dry eyes, irregular corneas, dystrophies, blepharitis. These have to be examined, treated, and explained to the patient in order to have a prevention of complications that may arise going forward. Of course, autoimmune conditions which target collagens like rheumatoid arthritis, SLEs, a slight chance of corneal melting post-surgery, not that it happens very frequently, but has to be documented at least in your sheet that these were looked out for and eliminated or taken off. So a good workup is important. There was a case reported long back about the pupil size and the zone of ablation. So those become pretty important in today's case also. I'm sure everybody knows about documenting the ablations and the scotopic pupil, how is the tear film, whether we excluded infections of the lid margins and MGDs. So these have to be taken care of. So the golden rule is what we would rather have others do unto ourselves. So we should pass on the same to our colleagues and patients. So we have to practice it ourselves and convey the message forwards. So do not do to your colleagues what you wish they should not do to you. Of course, avoid cheeky remarks, criticism, and do not say that the best person to do this kind of surgery is so and so doctor. So you are not causing some misinterpretation there. When we communicate with the public, whether it's in camps or whether when we go for talks, whatever we communicate it has to be true. It should not lead to any misleading information, and even in testimonials you should not go very the communication must be very subtle. What we want to communicate is the benefits of the surgery, and it must not misrepresent the ophthalmologist credentials, training, experience, and if you have complications, you have to tell them about the things that happen. So these, just in case if there is a litigation, we know now that documentation is important. It is always important to involve a team if there is a complication. If you're practicing as a solo surgeon, it's always important to involve a specialist who is senior in your area of practice, to have at least a second opinion, and we need to treat the complications as per the standard, or refer to a person of authority or a person of knowledge in that case. 50 lakhs is minimum. I would suggest 1 crore as professional indemnity insurance for people who have heavy refractive practice. And of course, all of us are members of local bodies like IMA, AIOC, Maharashtra Ophthalmic Society, and things would be a little difficult. Just in case if we have any complications, say for example in this particular case like infection or flap complications, it's important to calm down the nerves, counsel properly, see the patient daily, give important instructions, what to do, what not to do, when to follow up, and in case if the doctor is not reachable, who is the second or third line in line who can see, and the documentation of that consultation is also important. So at the cost of saving yourselves, though it is going to be time consuming, maybe 3 minutes, 5 minutes to write it, it is important in the eventuality if we land up in a litigation. So please document. And when in doubt, as I said, refer to a senior surgeon or a senior hospital. It is always important to involve a team which includes a senior person, and have a team opinion. So it has seen the greatest malpractice that we have seen is analysis of these claims show that this arises from if there is a delay in diagnosis or delay in referring the patient to a specialist. That's what the court looks for. This came recently from the Chief Justice of India bench, that a doctor is not negligent if he has acted in accordance with an accepted practice as proper, responsible by a body of medical men who are skilled in that particular aspect of surgery. So it is also held in the realm of diagnosis and treatment that there can be difference of opinion between two doctors if it is accepted that it was done in the best interest of the patient, and this will be decided by the senior ophthalmologist in that region. In this case, it's government doctors from the city from the head of that state. So it is always important to that even if somebody says that you are negligent, if your actions or your documentation say that you acted in accordance to the standard accepted practice on treatment and timely referral, it does not the case does not hold good against you in the court of law. Even in case of criminal negligence, the investigating officer needs to obtain an independent and competent medical opinion, especially from a doctor in government service of higher stature in that area. So these are the rules and guidelines that have been set by the Chief Justice of India bench and have followed by the Government of India and state medical councils. In order to protect ourselves from having litigations and going to save our fellow people, it's important to have good communication. So communication is the key, whether it's video based, it has to be in local language. Everything needs to be documented. Documentation is very important. Consent explained in the patient's layman's term. Own your complications. It does happen to everybody. We cannot say that no, there are no complications in my hands. There are going to be complications. Own your complications. Treat them to the best of your ability. If in doubt, ask for a second opinion. Refer to a specialist. Involve a team of specialists. Please carry a big amount in your professional indemnity, and counseling of the patient is the key to avoid litigations against us fellow doctors. Thank you, everyone, and I thank you for your attention. Thank you.
Thank you, Dr. Ashish. We can take any questions if there are any, because each topic is based on one specialty of the eye. So if you have any refractive questions, we can take it now.
Yes, sir. Yes, especially if you see worldwide, not just in India, it is more for laser refractive correction. So there is a website which is India Kanun, which I happen to search it. There are more against refractive person, but now you cannot distinguish as cataract or refractive are separate, so they are the same. So it is entire gamut is for us general ophthalmologists. Yeah.
I think it's because when they come for refractive surgery, they have a 6x6 visual acuity with the correction. So we are basically working on a normal, an eye
Exactly.
with a full good visual
Exactly.
protection.
Yeah.
So they notice a drop much more than a cataract surgery patient.
Even some cataracts are 6x6 these days. So yeah.
That's true. But they have some visual complaints.
Yeah, I agree. Thanks.
Yes, ma'am.
Just wondering whether, what is the time that most people take their consents for any type of surgery? Whether it is, you have explained to the patient everything. But then when you go to the operating theatre, at that time when you ask the patient that, look, I had told you this, the patient is blank. He is not, that means, understood anything. And which is, let's say, in even educated patients, there are few of them who don't understand. Most of them, rather, few of them who understand, most of them don't understand. Uneducated, they understand nothing. So, when is it that you all take your consents? At the time when you are seeing them and explaining everything, or at the time in the operation theatre? Because in the theatre, you also under stress. So when you all take it?
At the OR, ma'am, it's more like putting a gun on the patient ki sign karo, surgery karo, something like that. It's always better when they come for the workup, that a counselor sits with them and explains it to them in their local language, and they can take a consent before you call them for surgery. That's how I practice. I'm sure everybody has.
So your counselor does it or you do it?
We do it and then go to the counselor for taking care of the entire effort.
Yeah, so that means you all are getting the counseling, rather you all are first explaining,
Yeah.
getting the consent.
Absolutely.
And then they go to the counselor. But basically you're doing it in front of them.
So that's a
Yes.
very good point. I think all of us should pay more attention to when we take the consent, because I think 90% of us are still taking it just before the patient is
surgery.
wheeled into the operation theatre. Like he said, it's now you're already there, so you better sign it, whatever it is. So ideally it has to be at your consulting chamber. So there is a practice where you give the consent form to the patient and let them read it. They sign it and get it when they're coming for the operation. So when you're counseling the patient, they take it home, they read it properly, sign it and get it back to you when they are getting operated.
So what will be the date on that consent form, sir?
Has
What
to
will
be the
because
date of
because
surgery.
NABH mandates morning, means on the day of surgery.
It
The
still
patient
has to be
Has
the
to be.
date of surgery.
it has to be the date of surgery.
Yes.
The patient may read it beforehand.
Yes.
Yes.
Can I make a comment?
Yes.
Yeah.
I think we should mention two dates. One is the today's date when he's signing the document, and second is date of surgery. And secondly, I would also suggest that you mention that both the eyes will be done in the same setting. That should be specified.
Yes.
So one simple query I had, sometimes there will be residual error, and after 3-4 months, some patients come and ask for refund of the amount. So how do you tackle such patients?
I just wanted to add a point. I'm Dr. Savri. I'm from, I work in a multi-speciality doing oculoplasty orbit, so it's a whole different scene for us. But to what Sir said, so we have a very good, basically a legal team which guides us. So this had happened once about these 2 dates, and she was very clear that you should try not to put 2 dates, because though it is technically correct, it allows the person who's suing you or making a litigation to give you that leeway ki इस दिन पे बताया था फिर बाद में बताया था. So she said try and explain whatever you want, write it in your notes, in your file, in your OPD sheets that this has been explained. So we've started doing this, which I'll show in my presentation. Patient explained about this, and it's countersigned on the OPD sheet, and then consent is taken separately again on the day or before, but the date is of the date of the surgery.
Video consent. Yeah, it's not mandatory as much as I am aware. A written informed consent is what is expected, but it's good to have a backup as a video consent. Sir, for your question, never refund anything. You are saying that you did something wrong and you are intentional about it. Never do that. Never encourage that practice of refunding anything. Of course, own your complications. Say that this can happen in 4%, 3% of the patients, and we'll retreat it or whatever we want to do to the best of our ability.